Welcome back. This is part 3 of the Blocked Dog webinar as part of our recent graduates programme in the Langford Academy. So we'd established at the end of the last video that we've got a dog with a urethral obstruction due to likely a cystine stone. There's one in the urethra at the level of the os penis and one in the bladder, and we were discussing how we were going to manage that case initially. So I put some possible options up here. So I think the first one, as we talked about in the Blocked Cat webinar that preceded this one, is urethral catheterisation. I think the slight difference with dogs is that what you don't want to be doing is using a catheter to force a stone back into the bladder. So if you have got a stone stuck at the base of the os penis, really we want to be careful not to traumatise that urethra. So what we don't want to be doing is forcing the stone back into the bladder using a catheter. You'd cause quite a lot of trauma. You could, in theory, rupture the urethra, although it is a bit harder to do in dogs. But also, you're probably unlikely to get that stone to shift. You've got a long way to push it all the way from the os penis back to the bladder. So actually, there are better ways of doing that. So passing a catheter initially, firstly to assess for an obstruction, is quite useful, and also if you can get a small catheter past a stone, you can then use that to drain the bladder, and that can help in the emergency management of these cases, but I wouldn't be using a catheter to force a stone back into the bladder. What we then actually preferably do is a retrograde urohydropulsion, and so what we're going to do this is that we're going to instill saline usually and use that to force the stone back into the bladder. This does take 2 people to do it properly, and actually we have a fair number of these cases referred where referring vets aren't able to get these stones to budge, and actually we are able to do it here, and I think that probably comes down a little bit to technique. So my tips for doing this is that first of all you want to get a really good seal around the urethra. So what we would do here is we place a Foley catheter into the tip of the penis and probably about 1 or 2 centimetres in, so it's lodged within the os penis. I tend to place that in dry, so no lube, and that just means there's a bit more friction. It will stick in the urethra a little bit better. So once the Foley is in the tip of the penis, you're then going to inflate the balloon, and I do that quite forcibly with saline. So I'll be pushing on the syringe as hard as I can, and then release the syringe while you've still got that pressure in there, and that will inflate the balloon of the Foley inside the urethra in the penile portion, downstream of where the stone is, and you've then got a really good seal that shouldn't then come out. It should be stuck in there quite rigidly, and certainly for me I much prefer that to doing something like an Alice tissue forceps or a tongue clamp. It's much less traumatic for me, and I've certainly never ruptured a urethra by doing that. One of the things that I do also do before I put the catheter in is just cut the tip off, so you need to be careful not to damage the balloon, but if you just cut the very tip off the catheter, that means then the saline is going to push forward rather than out of those side holes, which will also help. So once you've done this, you've then got one person ready to flush, and I would pre-flush that catheter as well, sorry I should have said, so there's no air in it. You then need to get an assistant, or you need to do yourself, is put a finger up the dog's anus, into the rectum, and you need to feel for the urethra where it crosses over the pelvis. So putting your finger up the bum, feel for the urethra where it goes over the pubic bone, and then you need to use your finger to squeeze down on the urethra and compress it against the pelvis. So normally I do that bit myself because then I've got control over how distended the urethra is. So I'll have my finger compressing the urethra, and then I'll get an assistant to inflate the urethra as much as they can with probably quite a big syringe, like a 50 or 60 ml one. When you feel that pressure building up and you can feel the urethra bulging, you're really pressing down on it, you then, in a pulsatile manner, just release the pressure on the urethra. And the idea is that the urethra will distend around the stone, and then as you release the pressure, that saline will then rush into the bladder and hopefully take the stone with it. And as I say, that often does work. There will be some cases where it doesn't work, but quite often that is quite successful. And then if you are able to do that, that means you can forget about the urethra completely, as long as there's no stricture or secondary damage that you would hopefully see on your retrograde. And then you can just do a cystostomy, and that's much simpler for the dog, much quicker recovery, much lower complication rate. Alongside doing the cystotomy, we would also recommend castration for the reasons we mentioned already. This is an entire male, likely with cystine stones, and so castrating will hopefully help prevent those stones from reforming in the future. So in terms of how to do the cystotomy, these are just some of my surgical principles for the bladder. So we try and use atraumatic instruments. So you can see the DeBakey forceps on the left of the top image there, that they're quite smooth and atraumatic compared to the rat tooths on the right. So rat tooths are fine for handling skin and quite tough tissue, but certainly for the soft tissues of the bladder, we want something relatively atraumatic like the DeBakey forceps. And the bladder does inflame very quickly. So, doing these surgeries, or particularly if these dogs have got cystitis, the bladder wall can be, really quite thick compared to the thin, sort of translucent bladder wall you would normally expect to see. Make sure the bladder's not drying out, so keep it moist at all times. Particularly don't have dry swabs on it or wet swabs under the operating lights, because they'll soon dry out and then you'll have almost a wet to dry effect, and you really don't want to be debriding a bladder during surgery. Minimise direct handling, so we'll always put a stay suture in these cases, and that would be the first thing that I would do, is put a stay suture in the cranial pole of the bladder, and then you're able to pull the bladder out of the abdomen, fix it in position, and do your cystotomy. If you have got electrosurgery available, try and avoid using that on any mucosal surfaces, but particularly on the bladder. Again, it inflames quite quickly, and the electrosurgery sort of damage does propagate quite widely and quite quickly, so do be careful not to use that, minimise it at all. And then lastly, try and avoid contamination. So, depending on what you're doing, you really don't want to have urine spilling everywhere, particularly if there's other sources of contamination. Try and keep those away from the bladder as much as possible. And the last image on the right is we tend to use the Metzenbaum scissors on the left rather than Mayo scissors. Metzenbaums are much finer, they're often much sharper, and they will cut the bladder much cleaner than the Mayo scissors would. So just to talk through how I would do a cystotomy then, you're going to do a midline coeliotomy, so we'd always go midline. The image here is just showing that in males you can go transprepucially, so you can go through the prepuce, obviously not through the penis, but through the prepuce, pull it to the penis to one side, and you'll have the linea alba there. And that was reported quite nice in this paper that Pierre Montevin published in VetSurg. Once you're into the abdomen then, you're going to pop the bladder out, as they have in this photo here. And as I say, the first thing I would do is place a suture in the apex of the bladder in the cranial pole, and then I would use that, actually put a stay suture, so I put an artery forceps on there, and then use a towel clip to attach that to my drapes, and that way the bladder is fixed in position out of the abdomen, it doesn't move around. Ideally then you want to do another 2 stay sutures lateral to the proposed incision site. So find an area where there's not loads of blood vessels on the ventral surface, put a couple of stay sutures in on either side, and then we're going to use a clean number 11 blade to stab through into the bladder lumen, and then extend that incision with the Metzenbaum scissors. When we're finished removing the stones, doing whatever else we need to do, the first thing is actually just to make sure that we definitely have got all the stones. And that's a real issue for vets in practice and us here, is making sure you've got all the stones. There's a few different ways that you can do that. One is just to pass a catheter and feel for any more source of obstruction during surgery. The second is to do either intraoperative or post-operative radiography. And if you're still not sure, then you can put more contrast in, especially if you've got radiolucent stones. And for us, we've also got a very small cystoscope that we can insert, but doing something to check you've got all the stones out. Because there was quite a nice study, and I think it was around 20% of cases had some residual stones left behind, so it's actually pretty high. Once you're happy you've got all the stones, then we need to think about how to close the bladder. So for me, I would just do a simple continuous appositional suture. You don't need to do inverting patterns, you don't need to do multiple layers, although sometimes if it's a really thick bladder wall, it's easier to do it in 2 layers, but you don't have to. There's a fair few studies looking at which suture material you should use, and it does depend on what bacteria in the urine, if you've got a UTI and so on, but actually you often don't know that at the time of surgery, so I tend to go down the route of using PDS because it's probably the safest one to use, or another sort of slow absorbent suture. One of the key things is you must include the submucosa. That's the strength holding layer of the bladder, but it's actually quite hard to see. So occasionally you'll see a very thin white line, which is the submucosa, but you don't always see that. So if you're unsure, I would say it's better to go full thickness than risk missing that submucosal layer. As you get more experience doing cystotomies and other sort of hollow organ surgeries, you can actually usually feel the submucosa. So when you push your needle through it, it feels like you've got a little pop and it feels quite secure. So you'll get used to feeling that as you gain experience. And then one of the really good things about the bladder is that any mucosal defects will heal really, really quickly. So it actually heals back to normal within 5 days, which is absolutely remarkable. And so if you were to put a scope in these dogs and look where the cystostomy had been done, that mucosa will be fully healed at 5 days. And then even the bladder wall, which is a little bit slower to heal, is back to full strength after around 14 to 21 days, which again is really impressive. So actually it means that you can almost get away with quite a lot with the bladder, but at the same time we want to follow those principles and do the surgery as best we can. So that's all fine, but what if you can't get those stones to move? So if you've got that stone stuck at the base of the os-penis, you've tried your retrohydropulsion, it's absolutely stuck there, what are you going to do next? So tune into part 4 and we'll cover that.